Welcome to our program brought to you by the Cooperative of American Physicians and CAP's Practice Management Services Committee. Today's webinar is part of CAP's Surviving and Thriving Through Healthcare Reform Series. It's titled Everything You Thought You Knew About the HIPAA Security Rule, but Probably Don't. This audio was streamed over the Internet to your computer. If you prefer to listen to the audio over the telephone, join using the instructions that were emailed to you. And please note that the presentation slides will be emailed to all attendees soon after today's event. It's now my pleasure to introduce your speakers. Jeff Mangelli is Chief Executive Officer of Ascentec. It's a nationwide provider of HIPAA compliance and medical IT management services. For more than 10 years, Jeff has built Ascentec into a nationally recognized leader in the field of healthcare technology services and solutions. He's lectured at industry events and is frequently quoted in national articles and publications on the subject of IT security and HIPAA compliance. Alan Ridings is a Senior Risk Management and Patient Safety Specialist at the Cooperative of American Physicians. He brings more than 30 years of experience in risk management and healthcare operations to CAP's Risk Management and Patient Safety Department. Prior to joining CAP, Mr. Ridings served as Executive Director for Mission OBGYN Medical Group in Mission Viejo and San Clemente, as well as Mission Children's Medical Group in Mission Viejo. There he developed and implemented risk management tools and assessments, instituted total quality management and continuous quality improvement processes, as well as researched and implemented electronic medical record systems for the group's practices. Additionally, Mr. Ridings was an area manager at Cigna Healthcare, managing risk management, workers' compensation, and third-party liability medical offices. And now, Alan, I'll turn this program over to you.
Thank you. Welcome, everybody. Today's program, we're going to talk about the essential strategies of HIPAA. In other words, everything you wanted to know about HIPAA. Our core objectives today are going to be identifying the components of the HIPAA compliancy, describing recent changes in HIPAA, sharing protected health information, and restricting health information. So what actually is HIPAA? As the regulations have been around since 1996, some of the things that we're required to do in the privacy regulations are to require healthcare providers and organizations, as well as their business associates, to develop and follow procedures that ensure the confidentiality and security of protected health information, or PHI, when it is transferred, received, handled, or shared. This applies to all forms of PHI, including paper, oral, and electronic. Furthermore, only the minimum health information necessary to conduct business is to be used or shared. So some of the things we're going to talk about in this program are how to support the obligations, how to support the compliance, how to secure records, have your staff knowledgeable, and help reduce your risk. Remember, the privacy rule creates national standards to protect privacy of personal information, whilst the security rule governs the security of electronic healthcare information. Each must be reviewed by organizations that are using or sharing information about individuals. Here's the core competencies of this compliancy. We're talking about the Notice of Privacy Practices, patient acknowledgments, PHI and ePHI, office risk assessments, and business associates.
This is Jeff. Alan didn't just change his voice. Welcome, everyone. We're also going to be talking about emailing of PHI and essentially sharing it with your patients and sharing it with other providers, copying and releasing of protected health information, and also what the requirements are regarding childhood and student immunizations. This has all come about as a result of the Omnibus Rule, which became effective in 2013. Prior to the Omnibus Rule, most of the HIPAA legislation dated back 20 years. Obviously, a lot had changed in that time frame, and the folks that manage HIPAA, the Office for Civil Rights, wanted to update the requirements, and actually their goal was to kind of clarify things. And to a large extent, they succeeded in doing that, but they also wanted to put more teeth into HIPAA, and that's why you're hearing a lot more about HIPAA violations and such. We're also going to be talking about your disclosure duties, what happens in the event of unapproved access to PHI, and what the new requirements are relating to your ability to sell or not sell protected health information. So Alan had mentioned one of the core competencies is the Notice of Privacy Practices. And that is, in essence, an agreement that you need to make available to your patients. So it requires every covered entity to develop and distribute this notice. It has to be clear. It has to be user-friendly. It has to be written not in legalese, but in human consumable language. And it has to discuss what's going on with the PHI and the ePHI. Now, there's a lot of these available on the Internet. Some of them date back before the omnibus rule. So it's important that you note when this, which year your Notice of Privacy Practices was originated, because one of the telltale signs is if it doesn't address your rights when it comes to selling protected health information, then it's outdated and you need to update it. When we talk about legible, we're also talking about not in 5-point font. So the Notice of Privacy Practices addresses HIPAA, protected health information, ePHI, and also how you relate to your business associates. So the requirement is that you notify your patients that their protected health information may be accessed by third-party vendors that you do business with. You don't have to name them specifically. If they ask, then you may be obligated to provide them with a list. Otherwise, our recommendation is just that you make them aware. There's a couple of different ways that you can do this conveyance of information. One, and something we certainly recommend, is that you have a poster or a binder that's in your lobby, your waiting room, where your patients can take a look at it. It's a good idea also to provide kind of an overview fact sheet. We recommend that you get a signed receipt and acknowledgement. And this can be done in a couple of different ways. You can have them sign an agreement to which you can leave them a copy, or you could just have them sign a one-page form that basically just acknowledges that they did have an opportunity to take a look at it and that they understand the requirements of it.
Now we're going to talk about how to release information online and how to release information in paper format. What the authorization is required to indicate on the actual form, or how the patient wants their information. Affected individuals must be notified when the types and uses of disclosures require authorization, that these disclosures will be made only with authorization, and if any information is going to be marketed or sold. Now, can an individual revoke their authorization? Absolutely. The privacy rule gives individuals the right to revoke this information at any time. An authorization that they have given, the revocation must be in writing, and it is not effective until the covered entity receives it. In addition, a written revocation is not effective with respect to actions of a covered entity that took place prior to the date of this revocation.
So some of you may have noticed that we actually kind of made a transition talking about the security rule and now a little bit about the privacy rule, because you kind of can't talk about one without talking a little bit about the other. So when we're talking about the release of authorization, we're talking about patient rights. And it's important that you understand that this is something that you need to pay attention to. The next release of HIPAA laws is supposed to be regarding release authorization and documentation. So from HIPAA's perspective, from the Office for Civil Rights perspective, this is an extremely important component of protecting protected health information. So to give you an idea of how important this is, the most privacy-related investigations revolve around impermissible use and disclosures of protected health information. So it is something that you do need to pay attention to. The new legislation, by the way, is past due. It was actually due a couple of years ago. When the omnibus rule became effective, this was supposed to follow right on the heels of it. But it's been delayed mostly because of staffing changes at the Office for Civil Rights.
So now we're going to talk about what is a written authorization. These are required for all inspections and or release of billing notes or any part of the patient's medical record, and a separate authorization is required for each release. The time limit. Now, in California, we have several rules that are different from the rest of the states, but please check with your state legal departments to see if your rules regarding releasing in timelines are the same as HIPAA or stronger than HIPAA. In California, a patient may request to read their medical record within 5 working days. So how do you do this? You must have an authorization or something filled out that the patient's requesting this. Even though it's not really needed on paper, because a patient can have a copy of their record or review their records at any time based on these timelines. But for your logging to make sure that you're in compliance with state, federal, and your local laws, the only way you're going to find out if you've honored that request within the timeline is if you have the authorization dated and when you've received it, so you've followed that rule. So copies of the medical record in California must be released within 15 days. Under HIPAA, it is 30 days. Under these guidelines, your facility should have unified policies and educated staff. There are applicable charges for releasing of records. Remember, California, we have reasonable clerical fees, and that is up to your facility what is a reasonable clerical fee. There's no set guideline on that. However, there is a set guideline on pages. You can add 25 cents per page for copying of these records. For subpoena or copy services, there's a minimum of $15. And records to support an appeal for a public benefit program must be provided at no charge within 30 days. So this would be your Medicaid or Medicare information. Also, when releasing information electronically on a CD or a USB thumb drive, you may charge for the labor and media. However, on these two media formats, we recommend or suggest that you have the patient bring in the media, and when you receive that media, run it through your virus scanner so you make sure that you're not receiving any kind of viruses into your network as you're copying records onto it. And the reason that is, if you were to provide the CD or USB from your stock and charge the patient for that, you may also give them a virus. Even though we know you're protected or should be protected for viruses, etc., they could come about afterwards and say, you gave me a virus. So it's suggested that, you have the patients or the person bring in their media program for you.
Yeah, and you know what? To Alan's point about the USB and CD distribution, if that's part of your practice right now, we would strongly encourage you to adopt a different way of doing that. There's so many potential risks involved in sharing PHI that way that it's not a great solution. There are plenty of better solutions available, patient portals being one such example. Thanks, Alan.
Oh, you're welcome. And there are applicable exceptions to releasing records or having an authorization on file. Patients that are members of and physicians that are members of organized healthcare arrangements, and that is your foundations at your hospitals, your medical groups that share information back and forth. Some of them even include insurance companies back and forth. So if members or your patients are part of these organized healthcare arrangements, a signature is not required to send that information back and forth because it's part of the patient's treatment plan. In the past, we've always requested an authorization to send it to the doctor next door that's treating the patient. HIPAA changed that. It's made it a lot easier for you to share that information back and forth within the organized healthcare arrangements. All entities can share this no matter what, as long as it's involved in the patient's health care. If it's a request just for records for something different than health care, then you might want to investigate a little bit further from your patient and find out that you are complying with the rules and regulations on this. HIPAA changed in November 2014, and this was because of our Ebola outbreak. We didn't, in the U.S., we didn't have a good opportunity to share information across state lines to different public health agencies, the CDC, etc. So when there's an imminent threat to public health, you may now share that information with entities or public health authorities across state lines, across county lines. And that way we can get the information back and forth faster so we can come up with hopefully a cure in a timely basis. Now, when you do receive your authorization to release records, please make sure that somebody in your facility that is knowledgeable on the requests review all of them that come in, especially a subpoena for medical records. It should be one of the caregivers or physicians or person involved in the health care that reviews this to make sure that you're in compliance, and also lets you to bring this information up to your medical professional liability carrier to help protect you if you are being sued. On your disclosure log, when you're documenting this, who's it going to, where is it going to, when's it going to? This disclosure log for things like this, even though it's not required to document it, it's always nice to have it on here so you can show that you've complied with the request of the authorization. Here's a sample of a patient request for authorization. And even though it says here for personal request as well as for future date, this is a California form. And California is a very private state, but all states are private. In the middle section here where it talks about drug abuse, substance abuse, psychiatric mental health records, tests for the HIV, diagnosis for treatment of HIV, and genetic testing, a patient needs to specifically authorize this information to go out by initialing next to these boxes. So if these boxes are not marked on the authorization, in California, you cannot release those unless the patient authorizes it. This is talking about personal requests. So the patient wants the record for themselves, like, document that you're releasing it to them and a future date. This date can be any date into the future when this authorization is going to expire. Now, HIPAA may come back and change that. We don't know, and say authorizations may be only valid up to a certain date. But as of now, they're valid indefinitely as long as that date is not expired. Now, if you're releasing records to another entity or another company that is not involved in the patient's care, then you would fill out the section here that talks about continuity. Now, some patients may fill out a record request to send their information to a family member or to maybe a medical office in another state that they're thinking of going to see, but they haven't had that face-to-face encounter yet. They're just sending the records onto it. So that this request would show continuity of care, and the specific date would end, the duration would end on a specific date. Also, regarding childhood immunizations, a covered entity may release student or childhood immunization records to any school or any college without authorization if your state law requires the school to have the immunizations on file. Yes, you need to have it written or an oral agreement on file, document it in the patient's chart, or if you want to use your disclosure log, go ahead and place it on your disclosure log. Here's a sample of what a disclosure log looks like. These should be in the patient's medical record, or if you're on the electronic systems, these are already built into your electronic systems under record releases. This is a sample of what it looks like.
Yeah, I'm going to go ahead and answer Paula's questions. By the way, we see all the questions coming in. They're terrific. We're going to get to those at the end of the presentation. But Paul was asking a question relative to the authorization. One general authorization will typically be good if they give you if a patient gives you a general authorization. You mentioned also about faxing, which ties into what we're going to be talking about now. Emailing and texting patients, you'll notice that faxing is not on that list, and the reason it's not on that list is because don't do it. The only way faxing protected health information to anyone, particularly patients, is if you call them before you send the fax and have them standing and waiting at the fax machine to receive the fax. But if you look at the HIPAA breaches and the penalties that have gone down over the past few years, a number of them have included fax machines that stored copies of protected health information. Many of these fax machines are on networks now, and they have their own internal memories. And unless you diligently delete that stored information, chances are that protected health information is going to stay with that device. And when you take it out of service or when it gets sold or whatever happens to it, that protected health information now represents a breach. So generally speaking, faxing is to be discouraged, and you really ought to look at other ways of doing it. From covered entity to covered entity, it's less problematic, agreed. But when you're talking about covered entity to patient, there's a lot of potential problems there, particularly if you're sending it to the patient's office. So let's talk about emailing and texting protected health information. There are ways to do it where it can be HIPAA compliant. Basically, there's two types of emailing. There's what we call portal-based messaging, where you're not transmitting any protected health information at all, but you're inviting the patient or the patient's notifying you that they've created a message. And that process would typically involve logging into a portal to see what that message is. So there's never been protected health information in transit. The other type is secure messaging, secure email, where the messages are actually encrypted when you go to send them, and then on the receiving end, the user on the receiving end either is using that same encryption service, or you provide them with a key, typically verbally. Obviously, it doesn't make any sense to send the encryption password or whatever it would be in the email itself, because they won't be able to see it. So those are the two most common methods. Some of you will hear about what's called the direct protocol. There are a number of standards that are attempting to provide for this methodology and make it easy. The challenge with the direct protocol is you have to have a specific direct email address for each patient. And as a provider, let's say that you work out of one location and you have another location where you do some of your visits, and then you spend some time at the hospital. You technically have to have a direct email address for each location. So it's a little bit problematic and not as widely adapted as people would have liked. As a general rule, when it comes to transmitting protected health information, if you can identify the patient and what's being sent and the facility or the doctor that it's coming from, you're transmitting protected health information. Now, some of you may say, well, we're a primary care practice. If Joe Smith goes to this family medical center practice, we're not really disclosing anything. In that scenario, you may be right, but think about that being a fertility center or a contagious disease center or something like that. And that's the scrutiny that you'll be held to, not it was just a family care center. So a lot of people think, okay, well, encryption is the answer to everything, right? And the Code of Federal Regulations does highly recommend encryption. And encryption definitely helps. When you have data in transit, it's best to have it encrypted. And also, when data is at rest, ideally it can be encrypted. The problem with encryption is as soon as somebody has access via password, encryption doesn't work anymore. They've already gone through the encryption. And most breaches that occur because a user's identity is hacked. And we're going to talk a little bit more about that later on. So there are specific standards regarding encryption that you should use. AES is the most popular, typically 128-bit or 256-bit. And you have to implement the technical policies and procedures that are within your financial reach. So one of the things that you'll be held to is, was it financially reasonable for you to implement this technology? With something like encryption, that answer is going to be yes. So that won't be an excuse for you. It's not cost prohibitive for most practices to implement something like that. And here's why this is important. If you're taking your mobile device and you're going to a restaurant or you're going to the Starbucks across the street from the hospital and you're accessing protected health information through their Wi-Fi network, you are not going across a secure network. So in most cases, that's a wide open transmission of data, and we've seen breaches and penalties assessed because of that type of behavior. So we discourage that.
So now let's talk about treatment, payment, and healthcare operations. We've also always known it as TPO. What is treatment, payment, and healthcare operations? Well, treatment is the medical care in the office, all your electronic healthcare records, your mHealth, your telehealth, and those terms are all interchangeable. Treatment means provisions, coordination, and management of healthcare and related services among healthcare providers or by healthcare provider and a third party, like consultations between healthcare providers regarding a patient or a referral of a patient from one healthcare provider to another. Payment encompasses the various activities of healthcare providers to obtain payment or be reimbursed for their services of a health plan, to obtain premiums, to fulfill the coverage responsibilities, and to provide benefits under the plan and obtain and provide reimbursement for the provisions of healthcare. So what are healthcare operations? These are your medical office policies and procedures. These are the regulations and business policies. These are in place to cover the activities of the covered entity that are necessary to run its business and to support your core functions of treatment and payment. So what is needed when you have these in place is a business associates agreement. Business associates allow you to create and are needed when you create, receive e-health or diagnostic services, store, maintain any type of EPHI or PHI, transmit any protected health information on behalf of a covered entity. Now, a subcontractor is a contract that you have contracted out your services to. Think of a billing service. So your subcontractor will have a business associate agreement with you, but your billing service may contract out to another company. So a subcontractor will have a business associates agreement with the other entity as well. So it goes downhill. Everybody is saying that they will follow the business associate of the original party, which would be your office. This is needed when you're sharing any kind of data across lines, across data, etc.
So in the omnibus rule, they introduced a body of law that's well established with substantial case history called agency relationships. And believe it or not, the omnibus rule, other than Alan and I, most of you are probably here because you feel like you have to be. Some of us really like this stuff. When it comes to the omnibus rule, it is your friend because the business associate agreement actually gives you the opportunity to shift liability from you onto your business associate. So it's very important that you stay on top of your business associate agreements, that you get your vendors to sign business associate agreements. When in doubt, get them to sign it because it shifts liability to you. However, there is a circumstance where that chain of liability will not transcend to the business associate agreement. Let's use Alan's billing company as an example. If you are using a billing company, but you are micromanaging how that billing company is performing their tasks for you, then it could be argued that they are not an independent contractor, that they're actually an agent working in your behalf. If that argument were to be held valid, then you inherit that liability. So instead of having the disconnect over here where they would be deemed a true independent contractor, they're actually an agent of you. So be careful with your business associates how you manage them. If you're creating an agency relationship, then be aware that you're not taking advantage of the power of the business associate agreement under the new omnibus rule.
Next, we show a sample of what a business associate looks like. It has to have an effective date, and it talks about who are the covered entities and who are the corporations. Like I spoke about earlier, this is a California sample form. Your state may have different forms, or you may download samples of these from actually the Office of Civil Rights and go to search under HIPAA for the federal government. So you will receive copies of these. These should be reviewed often, and especially if you've made changes in your business. And what do we mean by that? Say that you're using a billing service, these two examples that we're using, and the billing service is ABC Billing Service, and you note that in your Notice of Privacy Practices poster or binder that's in your lobby. But you make a change, and you're now using XYZ Billing Service. You've updated, you've got a brand new business associate agreement, but you need to also update your Notice of Privacy Practices to show that you are now in association with a different company. Now, what happens if you don't update your business, if you don't update your Notice of Privacy Practices and your patients find out that their records are no longer going to ABC, they're going to XYZ, you could have a violation or breach there because you haven't informed your patients. So always review your business associates and always review your Notice of Privacy Practices to make sure that you're in compliance with these rules anytime you make a change. A suggestion may be on your Notice of Privacy Practices is to not name individual companies that you have associations with. You might want to put in there words like, we have several business associates that we share information with. Please ask to speak with our privacy officer for more information on who we share your information. This is almost exactly the same as information that we receive from the general public as well as from our banking information. If you look at banks, every so often you'll receive, here's our Notice of Privacy Practices. This is how we share information. So it's not just healthcare that does this. It's almost every entity or every type of business across the United States that share information regarding your personal protected information.
So one more note on the business associate agreement. Much like the Notice of Privacy Practices, there are dozens, hundreds of examples of these across the Internet. But as a result of the Omnibus Rule, things have changed. So specifically what you would want to look for to make sure that your business associate agreement is more current is that it specifically requires the business associate to comply with the HIPAA requirements. Most of the older ones will not have that type of verbiage in there. Also, again, same as Notice of Privacy Practices, where it talks about their rights when it comes to the sale of protected health information. So look for that. You know, we get this question all the time. Is this person a business associate? I was actually at participating in a regional medical association meeting on HIPAA with one of CAP's competitors, and they mentioned when this subject came up that if you have protected health information laying around the office, charts out, what have you, not locked away, then you should not allow people into your office unattended because they may see that information. But technically, your janitor does not fall into the category of a business associate because it's not in their normal course of business to be accessing protected health information. That's one of the standards. However, that doesn't mean that you should just say, okay, well, they're not a business associate, so we're just not going to do anything. What we recommend is that you have them sign a confidentiality agreement. Same thing with your landlord. Anywhere where they don't exactly fit being a business associate, if they could potentially inadvertently have access to protected health information, then put them on notice by documenting a confidentiality agreement. Very few vendors will take issue with something like that. And it's a good way to give yourself a layer of insulation where a business associate agreement either may not be applicable or they would be unwilling to sign it. So the answer is no, he's not a business associate, but yes, get a confidentiality agreement signed.
Thank you, Jeff. So now let's talk about breach notifications. Here's your duties under the Federal Register. What is a breach, it's unauthorized acquisition. It's accessing, its use, its disclosure of unsecured PHI in a manner that's not permitted by the HIPAA privacy rule. It also compromises the security or privacy of PHI. Covered entities and business associates are required to report such breaches of unsecured PHI and ePHI. Do we have to notify our patients? Jeff, do you want to talk about this?
Yeah, the short answer is in most cases, you probably do. The reality of it is there's where you have exposure is if you do not report a potential breach to your patients, and you're fairly certain that an actual breach occurred, if you don't report that to your patients, then the potential for one of those patients to complain to the Office for Civil Rights exists, and that's how you would get in trouble. And right now, because of limited finances and staffing abilities for the Office for Civil Rights, most of the audits that are occurring are either part of a very finite group of randomly selected ones, or they're being triggered by patient complaints. So what Alan and I would tell you the law is to be conservative, and if there's doubt, you should notify your patients. But we also recognize that you have a business risk and a business decision to make on your own end with whether or not you should be notifying them.
Thanks, Jeff. Okay, so regarding breach disclosure duties, if it's less than 500 patients, covered entities and business associates are required to notify the OCR no later than 60 days from the end of the calendar year. So what you want to think about here, say it happened on January 1st. You have until Halloween, technically, to report this on the OCR website or the HIPAA website. We recommend that you document it ASAP, but it must be done before 60 days from the end of the calendar year. That's for less than 500 patients. You should also notify your medical professional liability carrier. Bring them in the loop because, medical professional liability carriers like CAP are here to protect you and help you through this process. And it is a tedious process. It's cumbersome. There's lots of paperwork. There's lots of information. And it's stressful. So we're here for you on that. And the website below is how to follow the instructions right there. Now, if it's greater than 500 patients, you're required to notify the Office of Civil Rights within 60 days of the breach. You must notify the media, newspaper, television. Believe me, they'll find out about it. And how do they find out? Well, think of what happened with the Blue Crosses, the Blue Shields, your Targets, your Home Depots, etc. People find out about it. And, it's required under healthcare to notify these agencies. You also must notify or provide to the affected patients 1-year free credit monitoring service. And credit monitoring services could cost you, up to $125 to $250 per patient. So if you have 500 patients, that's over $60,000 worth of money that you're going to have to pay out immediately just to get these patients protected under their health for their credit, etc.
So what you're required to do in the event of a suspected breach is document what we call an incident risk assessment. We call it an incident risk assessment because many of you may be aware that there is an annual requirement for you to conduct a risk assessment on your facility. And this is, we distinguish between the two because an incident risk assessment covers a very finite number of factors. Basically, what you have to document is the following: the nature and the extent of the protected health information involved, the unauthorized person who used the PHI or to whom the PHI was disclosed, whether the PHI was actually acquired or viewed, and the extent to which the risk to the PHI has been mitigated. So basically, in the event of a breach, the Office for Civil Rights is going to want to know three things. What did you do before the breach? So were you in compliance? Were you up to date with all your policies? Had you implemented all the proper technologies? What did you do when you discovered the breach? What did you do to dig into what happened? what did you do? Did you notify your patients? What have you done when you found out about it? And then what have you done since? Have you implemented new policies? Have you made changes to make sure that same breach can't occur again? So the incident risk assessment is your formal document that you will provide to the Office for Civil Rights. And also, if you elect not to report the breach, because there are circumstances where a breach report would not be required, if you choose not to disclose the breach, you still have to document that you have an incident risk assessment on file. So in the event you do get audited, you have this documentation in place.
So now let's talk about the differences between the incident risk assessment and an office risk assessment. Risk assessments help you and your organization ensure that you're HIPAA compliant with all the administrative, the physical, and the technical safeguards. You should do this at least once per calendar year. And what a risk assessment will show you is parts of the assessment where you may be lacking or where you may be exceeding. So let's take a look at one line here, and that is a risk assessment number 1. Password changes are not enforced and set to no expire. What's the threat? What's the risk? What's the summary? What are you going to do to fix this? How high is the impact of this? And what are the recommendations? This is your plan of action. This is saying that we notice that this is going to happen. This is the vulnerability of it. And at the end is your recommendations of how you're going to fix it. You need to keep these at all times. So every year when you do a risk assessment, this may pop up there, and at the end, this particular question may pop up there. At the end, you've taken care of it. So you're in compliance with this technical part of this risk. But all the other types of risks that are out there, you should document on this type of a form and then show that you've got it on file in case the Office of Civil Rights or any state or federal agency comes in to say, show us your risk assessment, we're checking Department of Health Services, et cetera, may come in.
It is required for meaningful use. So if you're pursuing meaningful use, this is one of the MU requirements also. But even if you're not, it's still a HIPAA requirement that you do it annually.
So let's review what's required of you. What we've gone over is the medical office requirements. Make sure you have a secure registration process, face-to-face and patient portal. Make sure that your notice of privacy practices, this is your HIPAA, PHI, and EPHI. Make sure you have a poster, notice, or binder in a lobby available for the patients. And it's not only for patients, remember, it's for their representatives that come with them as well, their parents or their children that come with them that are make sure that they understand that this is the notice of privacy practices for this office. Remember, it's not just for patients, it's for anybody that comes into your facility. Also, business associates. These are required, these agreements are required for anything that you're transmitting on behalf of the covered entity. HIPAA education and training for all staff. Whenever you're training your staff or having them go through their HIPAA certification, shall we call it, they need a sign-in sheet. Many offices don't use a sign-in sheet. Certain rules and regulations in certain states require you to have a sign-in sheet after every education program. So make sure that you're in compliance with the rules of your particular state, but it's always good to have a sign-in sheet to show that you've had this education for your staff. And also, it's a trigger for you as a recall and tracking. So if some of your staff members are missing that day, you see their names not on that list, you need to get them back into a training program ASAP to bring them up to date, and also their signature of the understanding of the acceptance of what HIPAA training is. Your risk assessments, as Jeff spoke just a couple seconds ago, regarding regularly scheduled assessments. Minimum once a year is what is required.
So we've talked so far about what you need to do in order to be compliant. We're going to change gears to highlight what are the most common ways that practices and providers are getting themselves in trouble. So we're going to cover 8 of the most common causes of violations. Number 1 is authorized users. The weakest link in the security chain is the user. If you doubt that, then in 2014, the most common password was the numbers 1, 2, 3, 4, 5, 6. Number 2 on the list was the word password. Now, those were unchanged from the previous year, and I can tell you, having tracked this for years, they usually flip back and forth. By the way, it doesn't get any better. Number 3 is 1, 2, 3, 4, 5. Number 4 is 1, 2, 3, 4, 5, 6, 7, 8. So if you have those types of passwords that your staff is using, then you need to increase the level of complexity in your software to prevent that from happening. And you also need to implement regular changes of your passwords. Most systems allow for 60-day or 90-day increments to require users to change their passwords. So sharing passwords, that's another no-no. I know that never happens in a medical practice, but just in case it ever did, that would be bad. Obviously, sharing protected health information on social media, not good. And we've seen some of this recently, by the way. It's fine if you're a nurse and you go home and talk to your husband who's a reporter and you share photos of an athlete's injury and he goes and reports that. He's not in trouble, you are. That may change, by the way, but that's as it stands right now. So here are some examples of fines that have been levied for failures to conduct or update risk assessments. And what's important, other than the dollar amounts, which are substantial, what's important on this slide is to note the common verbiage. It's potential violations of HIPAA. So the standard that you're going to be held against is not did a breach occur or didn't it, it's could it potentially have happened. Here's an example. If any of you are running XP operating system on your network right now, or you have Server 2003 running on your network, and those have potential access to protected health information, you have a potential violation of HIPAA. If you were to get fined for some type of a breach, on the list of fines which would incur an additional dollar amount would be that you had an outdated operating system on your network. That's how the fines ramp up from $25,000 to $50,000 to $100,000 plus, because every incident is almost always the incident itself and then a violation of your policies, as an example. So number 3 is failure to consider or properly implement new technology. We talked about this before. If you are backing up your network over a cloud system and it's not encrypted, that's a problem. And when I talk about encryption, we're actually talking about 2 different types. There are backup systems that encrypt on your server and then transmit the encrypted file or files, and then there are those that you transfer it unencrypted and it gets encrypted at its destination. So it's encrypted at rest but not in transit. We would discourage that type of a solution and encourage you to go with a solution that's encrypted in transit. Failure to properly identify your business associates. Again, if you have a doubt, is this person a business associate or aren't they, try to get them to sign a business associate agreement. As a covered entity, it is absolutely in your best interest to do so. Number 5, and this is kind of a big one, the HIPAA police, the Office for Civil Rights, they believe that there is a culture of convenience that exists in the healthcare industry. And I know some of you are smiling as I say that because you know exactly what I'm talking about. It's just as a matter of workflow to get things done. A lot of staff helps doctors do things, helps other people help other people do things. So there's shared access to things under that other user's identification. OCR is hip to this practice. So that's one of the major things that they're trying to change. So what I would encourage you to do is to make sure that in your policies and procedures and in your regular practices, you are not creating the impression that you're doing things out of convenience or that you're creating risks as a matter of convenience. That is something that will get the hair on the back of their necks to bristle, which usually results in stiffer penalties. Failure to remember patient rights. Cigna got hit hard a few years ago for, in large part, for ignoring the request of the Office for Civil Rights, which they did repeatedly. So when the OCR finally did get them, they hit them pretty hard. But they also weren't responding to patients' requests for information. So an example of that is failure to allow access to the whole record. It is if you have information on a patient from another provider that had been referred to you, and along with that referral came some information regarding that patient, if you disclose that information to the patient as you're required to do, you can't not include that. You can't condition your privacy, your right to disclose information on whether or not the patient likes you, or whether or not you can't tell them if you go on Yelp, then we're not going to give you your records. You can't make things. You can't make the patient's access to their records conditional. And really, what we're talking about, and this came about in documentation form as a result of the omnibus rule, but it's also been an evolution. The concept from Health and Human Services is it's not your medical record, it's the patient's medical record. A lot of the new laws that have come to play, have been created because the patients now have stronger rights than they've had before. And it's important for you to take note of that from the government standpoint, the patient's on the record's not you. Forgetting about reasonable safeguards is number 7. So paper protected health information not safeguarded from theft. We've heard the stories of 192 patients' records left on a subway train. Information faxed to a patient's employer. Didn't include a confidentiality statement on the cover. But really, if you send, even if it's a work comp case, unless you're doing what I call point-to-point faxing, so that the patient or the person who's receiving that record on behalf of the employer who's authorized to receive that information is waiting at the fax machine to receive it. Again, we discourage the use of faxing, but we realize that it's impractical to completely eliminate it right now. So 8 is forgetting the minimum necessary rule. Your receptionist should not have access to a patient's complete medical record in the EHR by default. There may be cases where you could argue that was granted, but generally speaking, a scheduler or someone like that should have very limited access to the information that they can see. So the minimum necessary rule basically says if somebody doesn't need to see it, then they shouldn't have access to it.
And let me go ahead and chime in on one that was just recent here in California as well, a violation. It was quite a big one for a large HMO we have actually nationwide HMO. And what it was is regarding releasing of medical records. And this particular company failed to release records within the guidelines, 15 days for California or 30 days under HIPAA. And this particular facility refused to or didn't follow the rules on either case. So patients were requesting records for personal access, and they didn't receive them on a timely basis. This particular HMO was fined $865,000 for failure to follow HIPAA and California Medical Information Act. So it's not just all these small violations. There's other violations that kick in as well. So now we're going to open it up to questions, and we see quite a few questions popping up here. Jeff, do you want to take a stab at some of them?
Yeah, I'm looking. One question from Lisa. Alan, I'll let you answer this. Can we put the notice of privacy practices and the HIPAA disclosures on the same form? We
like to see them on separate forms. That way you've got one compliance versus another compliance. Now, if you have the notice on this form, the notice of privacy practices is very, very long. You might want to separate them out because if the patient revokes something, what are they revoking? So it's always suggested that you have them on two different forms.
So Darcy asked on the notice of privacy practices, I mentioned the 5-point font size is too small. There isn't a specific minimum requirement. However, there is a standard in the law that it needs to be readable and legible to a typical person. So generally speaking, you won't see many legal agreements in smaller than 8-point font.
And then Monica asked the question regarding an EHR system, or clearinghouse, such as Office Ally. Is it considered a business associate? Absolutely. Whoever shares information is a business associate.
So, Alan, this one is for you. Carla was asked if the $15 maximum or minimum for clerical fee for subpoena services.
In California, yes, it's $15 flat fee. You can't charge anything differently. That is civil code indicating how much. I think it's civil code 56 in California. It's $15 to release the records in the timeline allotted on the actual subpoena. So if the subpoena is not due for a certain date, you don't release those records until that date is up.
Janine, go ahead. I'm sorry, Alan.
Go ahead.
Janine asked if it's okay to charge for online access to a patient portal. My answer would be if access to their medical records is only available to a patient through the patient portal, then you should be careful in how much you charge. You should make that fee very reasonable. However, if you offer them different ways to have access to their medical record, the portal being one of them, then I would say you could be a lot more open in how you price that access.
And let me elaborate a little bit on that as well. When you think of your patient portal systems, several states have different age groups and categories for children or younger adults, shall we call them. In California, a child is an adult technically for certain diagnoses, sexually transmitted diseases, birth control pills, and so on, at 12 years of age. So on instances like that, your patient portal should have only the access for that patient, the child, and not their parents, unless the patient, the child, specifically authorizes their family members or whoever they want to be able to look at those records. We strongly suggest that you as caregivers have a word with the child or the patient saying you might want to speak to your parents regarding this because most likely they're going to get a bill for the services and it's going to come up anyway. So be a little proactive. But remember, your state, depending on where you are viewing this webinar from, may have different rules and regulations on age categories for children. But remember, each person should have access to their own records only unless it's authorized by that patient to look at specific information.
Susan asked about using a USB or a CD in the event of an audit or an insurance request for information that could be a huge volume of documentation. Sure, that is a different scenario. Of course, we would recommend that you either password protect the CD or encrypt the USB drive, but specifically be careful if you're sharing with patients that information, because even though it would be the patient's responsibility if they lost the USB drive with their health information on it, if it said Family Medical Center on the USB drive and had that patient's information on there, and that got picked up by somebody, it stands to reason that you would still find yourself under some scrutiny, even though it was the patient's responsibility. So that's the kind of situation that you would want to try to avoid. But when it comes to sharing high volumes of data like that, then we understand, again, try to make it encrypted or password protected if you can.
And also, we see lots of questions coming up of where can we get samples of these forms. If you're a CAP member, they are available on our website. If you're not a CAP member, they most likely are available from your medical professional liability carrier, or you can go to the HIPAA website, shall we call it, the federal government's websites, and they have samples of all these forms available for you. But when you get these forms, you need to make sure that you customize them and tailor them to your medical office, because there's lots of things in a notice of privacy practices. There's lots of things in a medical record release. You need to customize them for your practice and also make sure that you're in compliance with your state and your local laws for releasing of records or posting these forms, etc. But yes, they are available at several different opportunities for you.
If you're not a member of CAP, feel free to reach out to Alan or anybody on the CAP team. If it's any agreements or something that I've talked about that you want to get from me, feel free to contact me also. So Amy asked about logging in for accounting of disclosure if they're sharing information with a referring MD. Alan, go ahead.
If you're logging in and sharing information on an MD, now this could be taken two different ways and looked at two different ways. Say that the physician is involved in a surgery, and he needs information from a chart, but the person in the room, the nursing staff member, is not in the room, but he needs to get that information ASAP. The physician can authorize that particular person to grab that information, even though they're not involved in the care, and bring it to them, as long as they document afterwards that they've allowed this access for this particular reason and for this particular service. But releasing of records information, you should be involved in the medical care directly. Like Jeff brought up earlier on, receptionists that are not involved in the medical care directly should not have access to the patient's medical record. They should only have access based on their job duties, their specific functions in the office. Allowing people to look at all medical records could be a breach. It could happen at any time. And you don't want to put yourself or set yourself in that kind of scenario where everybody can see everything about what's going on with this patient. It should be specific, straight to the point for people that are involved in the care only.
And actually, Alan, there are quite a few questions about release of medical records and the disclosure log that we know you're all keeping very diligently. Yes, you can have one disclosure log for all of your patients. You don't need to have one per patient. You do need to make sure that log includes the patient identifiable name. So it can't just be we released so-and-so, someone's information to Dr. So-and-so. It's got to be fairly specific. If you're using an electronic medical record system, most of those systems, in order to meet meaningful use certification, will have that type of capability to report on accounting disclosures. And most of them will record everybody that accessed the patient record. And if you recall the UCLA incident or Cedars-Sinai incident from a few years ago, the way those providers and caregivers got caught was through the electronic medical record system, logging all of those celebrity record accesses.
Yeah, in addition to that, remember when you're using electronic records, everything you type on your screen, whether you hit the backspace, is recorded in the metadata. Now, metadata is the data underneath the data that you see on your screen. So if you have, let's say, a patient that's coming in and they're pain in the backside, shall we say, and they're upset because they couldn't find a parking spot or something, so they come in your office and they're really abrupt. And your receptionist or caregiver or somebody that's checking the patient in, shall we say, types on the screen, patient is a pain in the, and then realizes what he or she is doing and then hits the delete key and erases it. Well, guess what? That's not going away. That's hidden on those files. And so it's discoverable. And unfortunately, attorneys know where to look for these records now. They know exactly to ask for the metadata because it tells you exactly when that chart was opened, what time it was opened, how long that chart was open, who accessed it, who typed something, and it shows how long it's been idle. So if somebody asks you, well, how long have you had that chart open? And you say, well, it's only been open a couple minutes. Well, the metadata is going to tell the other story. It's the story underneath the story or the data under the data.
So Lisa asks, and this is an interesting question because Alan and I might actually have different answers. Can we release records if a patient writes a note but doesn't use our standard disclosure form? My first question would be, if they're not using your standard disclosure form, I might assume that they're making that request not in your presence. And so my first question would be, are you sure it's them? So in general, I would say yes. If you get something in writing from somebody, from a patient, and you can verify that it's them, and it's not on your standard form for authorization and you save that, I would say you're probably okay. Alan might disagree. What do you think, Alan?
Well, I don't disagree, but, we always strongly caution on protection. And like Jeff just indicated, you have to verify that it's the correct person. But technically, you could write a request on a blank piece of paper. I authorize these records to be released to. I want a copy of these records. The patient, yes, has to sign it and date it. We do put emphasis on having an official form, and that's why if you have an official form, then it's standard so all your staff members are educated on how it's working. You should have those forms available. A patient comes in and says, I want my records, then hand them the form, the approved form to release the records. You're in compliance that way. But going back, if somebody wants to write it on a napkin and they sign off and date it, and you can verify that this is that particular person, yep, you've complied. It's a written request. And if you look at the HIPAA guidelines, it says must be in writing.
So Joel asked, if records are subpoenaed for a lawsuit, does it matter if we release them earlier, or should we wait until as late as possible, or until the date that they actually expect to have them? Ellen?
Okay. The date of the release, you shouldn't release the records until that date. It's got a date on the form when the records are needed by. But when you are subpoenaed, the first thing I would suggest you do, and we would like you to do, is contact your medical professional liability carrier. Get them involved in this right away, and they will direct you on when to release, when not to release, and so on. And they'll also help you regarding what kind of a subpoena is this. Is it just a routine subpoena for records, or is it a possible lawsuit? Lawsuits usually come on a 90-day notice of intent or words to that effect, depending on which state you're in. But always call your medical professional liability and ask, for help on this when you can release them. We'll walk you through the steps on specifically.
Janine asked about faxing to surgery centers and such. Generally speaking, when you're conveying information covered entity to covered entity, you're generally in fairly safe space. It's where I would definitely be concerned, and that's where faxing as a policy can be problematic, because if it's faxing sensitive information as a policy and you get a patient request or you get an employer request, it can't be treated just as business as usual as if you were sending it to a covered entity. So generally speaking, covered entity to covered entity, you're going to be okay. But if you're not careful and it becomes covered entity to patient or covered entity to employer, it could cause problems for you.
And Laura asked the question, do we need a business associate agreement with an off-site storage facility? Absolutely. They're maintaining your records for you, so definitely get a business associate agreement with them, because they're responsible for upholding the privacy of those records. We have seen some instances where offices have put the records in a regular off-the-shelf storage facility. That's not a protected environment. Somebody has to protect those records from theft, from possible breach, from even fire. And when you send them to a reputable company that stores these records, they are protected in a manner a little bit higher than, or actually a lot higher than, your regular storage facility down the street. So yes, you do need a business associate agreement with that entity to protect the records. Think of the other side of the coin on that is when you want to retrieve a record from that facility, well, you're going to send information back and forth, so you are divulging PHI. So that's why you need the business associates agreement.
Okay. Anna asks if it's okay to email non-encrypted lab or test orders to patients, and we have another kind of similar question. Is it okay to email new patients appointment forms? I would say on the emailing lab tests to patients, no. I would strongly discourage against doing that. If it's not encrypted, I would not transmit it over email. It's too easy for that information to end up on somebody's website and gain access. Google, as you know, if they're using Gmail accounts, Google reads the content of those messages and targets ads accordingly. So that is not a good practice. I would strongly discourage it. We provide a service called Protected Trust, which is an encryption email service that plugs right into Outlook as an example. A portal. We also have a portal as another option. So if you're emailing protected health information through standard email right now, I would strongly recommend you change that practice. Alan Laura asked a question. A patient's family member, for example, a husband, daughter, son, or sister, is asking for patient information, but they don't have a written consent from the patient. Is it okay to release that information?
Well, if the patient's still alive, then the authorization is needed. To release to any person, anybody else, it's needed. So make sure that you do get the authorization from the actual patient, allowing their family members to have access to the record. Now, when I said alive, if the patient is deceased, there are certain rules regarding releasing to immediate family member, and I'm talking about California here, so your specific state may have a different rule on when they can release records. As long as it's authorized in California, what I mean by that is the deceased family members, immediate family we're talking about here, that's mother, father, brother, sister, step-parents, step-children, etc. That's immediate family. It's not aunts, uncles, and so on down the line. Once they fill out that record request, they have access to a deceased family medical record or deceased family member's medical record. But your state may have separate rules and regulations, so check with your medical board of that particular state regarding that. But in California, yes, you can release with authorization. Without authorization, no, you cannot.
And Renee, just to answer your question on emailing new patient forms, I would discourage that. I think you're generally in okay shape, but again, it depends on what kind of facility you are, and that's the way you should look at it. If you're the type of facility that is highly sensitive in the types of care that you render, then you probably don't want that patient's name associated with your facility in a public forum, and you need to consider emailing a public forum unless it's encrypted. So a far better solution would be to make those patient forms available on your website or through your portal.
Okay. I see we've almost answered. It looks like we've answered the majority of these questions. Please review the information that we're going to send to you for how to comply with a lot of these rules and regulations. You may email CAP and your medical professional liability and also Jeff regarding some of these other questions that we haven't had a chance to get to. I'm going to now revert this back to the moderators and open it up for them to continue.
All right. Well, thank you so much. That does conclude this presentation. Everything you thought you knew about the HIPAA security rule, but probably don't. Thanks so much to our speakers, Jeff Mangelli and Alan Ridings. Now, the Cooperative of American Physicians will email the webinar recording and the presentation slides as soon as both are available online. I know we've had a lot of questions about that. And any questions that have not been answered during today's Q&A will be answered offline and emailed to all of you within the next few weeks. This program is copyrighted in 2015 by the Cooperative of American Physicians, Incorporated, all rights reserved.
The information in this program should not be considered legal advice applicable to a specific situation. Legal guidance for individual matters should be obtained from a retained attorney.